I'm pleased also to follow Mark Edwards. He and I have often spoken at congresses together and spoken a lot, and our sense of things is relatively similar. And Mark has already given a good introduction to the issue that I've been asked to focus on, which is that of the issue of agency. First, let me just say that I have no conflicts of interest in this presentation. So I just begin with just a couple of very basic things, which I'm sure you've heard about already, and Mark Edwards commented on, but this is my own definition of functional neurological disorders. And I want to make sure that you understand what I understand by them. So it's a neurological disorder characterized by almost any type of neurological symptom, not voluntarily produced. And that particular issue is the one that I'm going to be focusing on in this talk. It's caused by a brain network dysfunction that doesn't exclude the possibility of normal function, sometimes due in part to a psychological cause, not explained by other neurological pathology that may or not be present, and the symptoms may be inconsistent or incompatible with other known neurological disorders, human anatomy or physiology. And that's quite similar, I think, to what Mark was saying earlier. You hear a number of those same phrases in his presentation. I just note that from the point of view of psychiatry, in the psychiatry manual, the DSM-5, functional neurological symptom disorder, parenthesis conversion disorder, is in the category of somatic symptom and related disorders. And I want to note there an important feature, that there's also factitious disorder that is in this particular category. And factitious disorder can look like functional neurological disorder. The main difference to a certain extent is that factitious disorder is voluntary. It is still considered a psychiatric abnormality in the DSM-5, but there is a need to produce the disorder, and therefore it is voluntarily produced to satisfy that specific need. Now, in this same listing here, I have put malingering. Malingering is not in the DSM-5. It is not considered a psychiatric abnormality, but I put it there because it can come up in the differential diagnosis. And you heard that already from Professor Edwards. And malingering, like factitious, is voluntary in nature, but it is not a psychiatric abnormality. Malingering is a situation where individuals have a specific goal. They don't have a psychiatric disorder necessarily. They are seeking a specific goal, like the acquisition of drugs or avoidance of arrest or something of that sort. So factitious and malingering are similar in that they're voluntary, but they can look like functional neurological disorder. And to a certain extent, they get confused in doctor's mind. So I think that there's this significant concern among those of us interested in functional disorders that functional neurological disorders have to be distinguished from factitious and malingering. And I think that while that sounds like a reasonable thing, and all of you might fully agree with me, there is a considerable feeling in the physician community and in the lay community that FND is not really involuntary. And interestingly enough, I'll give you a further proof of this particular issue. There's this article that was published in Lancet Neurology last year. with I and a number of colleagues wrote about functional neurological disorders. And what we wound up with in terms of our review when we sent it in was this comment from the Lancet Neurology reviewer. Now, I don't know who this person is, but presumably is a reasonable person who understands generally what we're talking about. And we had a phrase in the original version of the paper that said symptoms and signs that are involuntary, just like the definition that I gave earlier and Dr. Edwards did, and I'm sure you've heard earlier as well. So the reviewer said, I think this is false. Although it is repeated throughout the article, the patient may not appreciate that they are voluntary, may not feel that they are their actions, but they are. This needs to be changed throughout. Now, I think that this feeling of the reviewer is just really incorrect. And what happened was we went to a back and forth argument. There were many comments, of course, in any review. We answered all of the comments, but this reviewer refused to accept the idea that functional neurological disorders are involuntary. And in order to get the paper published, the editor really sided to some extent with the reviewer, and we wound up taking the word involuntary out of the article. And we settled on another phrase, genuinely experienced symptoms. And the reviewer accepted that, and the paper was published. But this gives you a sense of, I think, about even how very knowledgeable, smart people, presumably that's what the reviewer is, have this sense that functional neurological disorders are not truly involuntary. Now, in relation to movements, and my own interest is in functional movement disorders. I'm a movement disorder neurologist. And I think you heard this from Mark Edwards as well, that there are many types of movements that can go on. We're interested here in the issue of voluntary movements, where there's a sense of conscious intent. And just like Mark Edwards pointed out, in fact, many movements that we make, we don't really think about whether they are consciously intended or not. We just go about them automatically. But even in those automatic movements, if we were asked whether they were voluntary, we would generally say, oh, yes, it was a voluntary movement. But that actually characterizes most of what we do. There are certainly involuntary movements like myoclonus, tremor, chorea. There are reflex movements. There are movements that occur from muscles such as fasciculations. So there's a variety of types of movements, but there truly are voluntary movements that have conscious intent. That's how we define a voluntary movement, and there are those that don't. Now, let's focus a little bit more on voluntariness. What does it mean to have a movement that is voluntary? There are two aspects to it. One is the sense that you will the movement. You are wanting that movement to occur. You intend that movement to occur. You initiate the movement. You have that sense of willing the movement to happen. And then there's another factor, and that is the sense of agency. In the sense of agency, you've already been introduced to that in Professor Edwards' talk. Agency is the sense that you are the one that produced that movement. The agent is that force that produces something. And that has to happen after the movement, of course, because you have to have something to be the agent of. So in relation to self-agency, that is the notion that you are responsible for the actions that have happened, that I made the movement that just occurred. And to get the feeling of causality, the sense of willing has to precede the movement. So you have to will or intend the movement. It has to happen in the way that you intended it to occur. And then you have agency for that particular movement. Now, agency, of course, can be for other things other than your movements. You can feel that you are the agent of other things. And let me just show you a cartoon from my favorite cartoon series, Peanuts, in which you see the sense of agency here. Linus is talking to Lucy, and Linus says, all I did was stand out here like this, and I said, rain, rain, go away, come again some other day. The rain stops. And Linus now has the sense that his saying that is the cause of the rain stopping. And so he becomes the agent of it. And it's frightening, isn't it? But this is something that I guess happens to all of us also from time to time. You do something, something happens, you feel you're the agent. That's the sense of agency. So what is interesting about agency particularly is that we know in the brain how the sense of agency arises. This is a process that has been studied by a number of investigators over the years, and the brain network responsible for agency is understood. And I say network specifically because almost everything in the brain, all the functions in the brain occur in networks. They're not just single spots, it is a network of operation. Now, many people have studied the process of self-agency, and we have too in our own group. And this is I'm going to show you the study that we did about self-agency, as you see here, is led by Feta and Ahab. And I will explain to you what we did in this study. So on the right-hand side of the figure, you see a hand in what's called a data glove. A data glove is a very nice device that records the angular movement of every individual joint in the hand. And that information can be received by a computer program, and you can do various things with it. You can just use it for measurements, but you can also do it, as we have done in this study, to drive a computer hand. So the computer hand is what you see on the left-hand side of the figure there. That is a hand, and you can use the information from the data glove to drive the computer hand. Now, if you have someone looking at the computer hand and moving the hand, you will see that the hand moves exactly as the real fingers do. And after experiencing this for a little while, you can feel that you are the agent of that computer hand. And in fact, you are the agent of the computer hand in that particular situation. But given that it's a computerized hand, you don't necessarily have to run the computerized hand exactly as the movements of the fingers. In fact, you can mix it with random movements of various types, and you can mix it in variable proportions. And if you can mix it in variable proportions, you might be able to modulate the amount of the sense of agency, because you are losing the sense of agency if you mix up random things in it. Now, the idea in this experiment was to do that with individuals in a MR scanner to look at what might correlate with the sense of agency, what parts of the brain modulate with the amount of agency that one experiences in this particular situation. So I will show you what this looks like. I will first show you 100% control, and then we'll modulate the control so you can see what that looks like. So this is now 100% control. The hand does exactly, computerized hand does exactly what the other person's hand does. This is now 0% control. There's no correlation between what the hand is doing. And this is now 50% control. There's 50% random and 50% what the individual is doing. Now, of course, I just gave you short tidbits. It's hard to get a complete understanding of that or a complete feeling of that just by seeing it, but it gives you an idea of what we did. It turns out that normal individuals are very good at telling how much agency there is. They do have a feeling of variable self-agency in this situation. So on the x-axis here, there is the objective modulated control condition, 100%, 75%, 50, 25%, and 0. And on the y-axis is the amount of perceived agency that normal individuals have. And you can see here that it is indeed modulated, and it's pretty close to what it should be. But even so, one can take the amount of perceived agency, which is indeed modulated, and correlate that with the bold fMRI signal to see what parts of the brain are activated or deactivated with a sense of agency. And this is the network that shows up in that particular situation. And it turns out that these are regions responding proportionally to the loss of self-agency. Nothing actually responds to the presence of self-agency. You have this response in the loss of self-agency. And the reason for that is that if you will it, it happens in the way that you want, the brain is not excited by that. That's the way that things should be. Your brain gets excited if there's not a proper match of what you willed and what happened. And that's a loss of self-agency in that situation. So these are the regions that respond proportionally to that. You can see that it's a network of areas all around the brain, and the largest activation by far is in the right temporoparietal junction. You can see that there. And interestingly, this is a right-sided brain function. Agency is a lateralized function. Just like language is lateralized, agency is indeed lateralized. Also, it's more on the right side of the brain than the left side of the brain. Now, just I'll show you a little more detail about this particular study. And different regions have different patterns. This is the entire pattern of the bold response in the functional MRI activity. The different colors are different percent of agency that people have. And there are regions like the postcentral gyrus and the middle occipital gyrus, part of the motor apparatus and the visual apparatus. They don't modulate with agency. They are active in all the situations. But you take another region, like the right temporoparietal junction, for example, and you can see that in this situation, there is a modulation of the right temporoparietal junction, depending upon the amount of agency. There's also modulation of other regions. I draw your attention to the right anterior insula, for example, the right superior frontal gyrus. These are areas that are well modulated by the sense of agency. Now, we contrasted a leading response and a lagging response. It's all part of the same network, but there were some regions that tended to respond a little bit later, and they tended to be more frontal in where we saw them. And this is a map of what we call the leading and the lagging areas. The leading responses were ones that were areas of the brain that were active early, and the lagging responses were ones that were more active a little bit later. And we thought that it might well be the case that the early regions are those that are particularly sensitive to mismatch, and the lagging responses perhaps more of the interpretation, but it's all the same network in the end. This is just a summary of what I just said. Just to point out a few more things about agency, it is possible to disrupt agency using transcranial magnetic stimulation over the pre-supplementary motor area. This is a study that was done in Patrick Haggard's laboratory. It turns out that if you are trying to time the different activities, you can do that with when you're watching a clock, and so you can time when certain things appear to you to be happening. You can time when you press a button, and you can time when that button produces a shock on your hand. Now, what happens is that if you time the button presses by themselves and shocks by themselves, you can time them relatively well. If you link them such that the button press produces the shock, then those two events become closer together. And that coming closer together is a sense of agency. And that sort of correlates with the sense that you are producing that shock. And what happens, you can see here in part A on the bottom, the filled circle is the timing of the button press. The gray triangle on the right is the timing of the shock. And you can see that when there is stimulation of the sensory leg area or the contralateral sensory motor hand area, these two events are coming closer together. If you stimulate the pre-SMA, they come closer together, but not as much as they did before. So you can interfere with the process of agency by stimulating a node of this network, in this case, the pre-supplementary motor area. I'm going to skip that slide. So let's talk about how this is happening in a little bit more detail. And this is a block diagram of how the brain is working in this situation of making movements and producing the sense of agency. You have the brain's intention for making movements, and the brain's intention comes from a number of different systems, the limbic system, which produces emotion, the parietal prefrontal system that gives you information about the environment, the frontal lobe, which has cognitive function, including the ideas of belief that you heard a lot about from Professor Edwards, and the hypothalamus and homeostasis and interoception of what's going on in the body. For example, if you're thirsty, you'll want to have something to drink. So all these things form brain's intentions, which eventually lead to movement generation processes, particularly in the motor system that will produce the movement. Now, from the brain's intentional systems and from the brain's movement generation system, there are feed-forward signals to the brain saying that I have intended to movement. I haven't willed the movement to happen. And from the movement, there's feedback. And if the feed forward and the feedback match, that gives you this sense of agency, the sense of being voluntary. And this is an aspect of consciousness that is called a quali. A quali are features of consciousness, and the sense of agency, the sense of it being voluntary, is a quali. Now, there's a great importance to feed-forward signaling in the brain. It is an extremely important aspect in the way that the brain functions. And I'll just give you another example of the importance of feed-forward signaling. When you have eye movements, it causes image movement on the retina, but you don't think that the object that you're looking at is moving. But if you have a situation of opsoclonus, for example, the eyes move and the images do move in that situation. With normal eye movements, there are feed-forward signals that are sometimes called corollary discharges from the frontal eye fields to the visual cortex. And those feed-forward signals make it clear to the brain that the eyes are moving, you expect the images to move, and therefore you have the sense that the images are still. But in opsoclonus, there's an involuntary activity of the saccadic burst neurons in the brainstem, and there's no feed-forward signal produced, and therefore when the eyes move, the images move. So feed-forward signaling is really critical for the functioning of the brain, including this aspect of the development of the quality of agency. Now, Mark has showed you our study of this before. I'll just show it to you again in perhaps a little more detail. What about functional tremor, where there's no sense of willing or agency in the patients who have functional tremor? And this is a paper that was published more than a decade ago now. Valerie Voon was the first author. And what we did in this study was to take individuals that had functional tremor that came and went. They could also voluntarily mimic their tremor. Now, there was no way that we could tell the difference between their burst of involuntary tremor and their mimicking tremor. It looked exactly the same. The patients could tell the difference, of course, because in one circumstance it was voluntary, and in one circumstance it was involuntary. So in the scanner, we could ask the question, well, what's the difference? Why in one circumstance does it feel like it's voluntary, and the other sense it does not feel like it's voluntary? So we had 8 patients. It actually took us 5 years to get a sufficient number of these 8 patients to actually be able to do this well. And you've already seen this particular image that Professor Edwards showed. The major difference between mimicked tremor and the functional tremor was in the right temporoparietal junction. And so we recognize this immediately as being a difference in the agency network. The network is functioning differently in the 2 circumstances and gives a biological basis for the failure of agency, the failure of the sense of voluntariness in the involuntary functional tremor. Just a little bit more about the imaging in this area. We also then looked at the connectivity between the temporoparietal junction, and we found that there was a decrease in the network. I pointed out that the agency network is a network, and there is not only an abnormality of the temporoparietal junction, but an abnormality of the whole network, the connectivity of the temporoparietal junction to other areas. And moreover, it turned out that we could find the abnormality of the right temporoparietal junction even in rest scans. And we could find, again, abnormal connectivity between the right temporoparietal junction and other parts of the sensory motor system. We then did another study, doing the study that I showed you already with the data glove and the computerized hand with a group of patients with functional movement disorder. Now, in this particular situation, the movements are fully voluntary movements that they are having. But what it turned out, interestingly, is that this network, the agency network didn't function normally in these individuals, even when they were making voluntary movements in this particular situation. And I'll show you that. So let's just look here at the anterior insula. This is this modulation that you can see very well on the left-hand side here with the variable amounts of agency. That modulation is lost here in the functional patients. And similarly in the right temporoparietal junction. On the right side here at the bottom, you can see good modulation, but you don't see that good modulation on the left side. So this whole agency network is actually malfunctioning in a particularly critical way in these patients, even in the situation where they're making voluntary movements. So agency, along with willing, is a critical component of voluntariness, and it's this match of feed forward and feedback that creates this sense of agency that I was talking about. Just to remind you again about this sort of diagram, the brain's intention and movement generation produce these feed forward signals. With the feedback, you're producing this sense of agency. Now, just to comment a little bit more on the brain's intention. I have been asked specifically to speak about agency, but that's only part of the story here. I think you've heard from Mark Edwards about the importance of belief in generating the brain's intention as being particularly important in the thinking about how functional disorders arise. And I know one more very important aspect, which has been demonstrated in a number of studies, and that is an overactivity of the limbic system. This has been identified mostly in regions such as the amygdala and the anterior cingulate cortex, but they appear to be overactive, driving intention perhaps in an abnormal fashion. So we have an abnormal formation of intentions due to abnormal limbic function, abnormal belief, perhaps abnormal interoception, a variety of factors giving rise to abnormalities of intention, which will give rise to abnormalities in willing. This is the sense of willing that is, of course, important for generating movement that is compared to the feedback to produce the sense of agency. So there really is a very important complex network here that is critical for understanding the whole story. So in conclusion then, persons with FND truly do have involuntary symptoms. They differ from persons with factitious and malingering, where the situation is voluntary. This information is useful in discussing the nature of functional neurological disorders with patients. You can be clear with them that they are not making this up. This is a truly involuntary disorder. And I think it's also important for explaining functional disorders to our colleagues. As I pointed out in the beginning, some of our colleagues don't even believe this, and we have to be clear that this is truly an involuntary disorder. And I've been involved with a new organization, the Functional Neurological Disorder Society. It has an important goal of education, and it should be able to be helpful in this particular aspect, as well as many other aspects. And I just did my last slide point out that the Functional Neurological Disorder Society is a thriving group. We're going to have our second meeting in Verona in June 2024. And for those of you interested in functional neurological disorders, it would be a great place to go. So that's really what I have to tell you today. And I'm happy to have this opportunity to talk with you about this. And I look forward to answering questions and having a discussion with you a little bit later in the program.